Hello, and welcome to this workshop series, Preparing for the New Era of Blood Based Biomarkers and Alzheimer's Disease Navigating Guidelines, Policy, and Practice Workflow Integration. I'm Suzanne Schindler, Associate Professor of Neurology at Washington University School of Medicine, and today I'm happy to have Lauren VandeVrede, Assistant Professor of Neurology at the University of California, San Francisco, join me for Workshop 3 so that we can talk about how to put blood based biomarkers to work in real world Alzheimer's disease care. Welcome, Ren.
Thanks for the invitation.
I'd like to thank PeerView for providing the session and Lily for providing the educational grant for this workshop. Just a reminder to look out for polling during this presentation. Submit your questions and we will answer them in the chat window. You can visit us at peerview.com/plasma for the slides, practice aids, and additional resources. In the first two workshops of this educational series about blood based biomarkers for Alzheimer's disease, we discussed the rationale for using blood based biomarkers to facilitate an early diagnosis of Alzheimer's disease and reviewed the appropriate patients who may benefit from these tests. We also reviewed test performance data and advised on which blood based biomarkers are the best predictors of amyloid pathology, and we provided guidance on how to interpret the blood based biomarker test results. These workshops are available on demand if you missed them or if you would like to re-watch them. During today's workshop, we will learn how to integrate blood biomarker testing into real-world practice to improve the early detection of amyloid pathology in patients with cognitive decline. We will also learn how to educate patients about the implications of their test results and to coordinate follow-up care to support treatment planning. We will begin by discussing the clinical implementation of blood based biomarker testing in primary care and general specialty care settings. So, what is the rationale for using blood based biomarker testing in primary care? Well, it's really because primary care clinics serve as the front line of diagnosis and screening efforts for many conditions, including Alzheimer's disease. Now, these new FDA approved disease modifying treatments for Alzheimer's, lecanemab and donanemab, have really increased our need for biomarker testing because to be considered for these treatments, you have to have biomarker evidence of amyloid pathology. And we really need primary care doctors to be able to do some of these tests to enable adequate testing in a timely manner while reducing the specialty care wait times. Now, certainly, if you have complex cases or think someone's very likely to be eligible for amyloid targeted treatments, so for example, they have positive blood based biomarker tests and abnormal cognitive test results, we would recommend uh, that they see a memory specialist, certainly before their disease progresses, because as their disease progresses, they become ineligible for treatment. There have been some modeling studies done that have shown that adding blood-based biomarkers to traditional cognitive testing can substantially reduce wait times for these memory clinics from about 15 months to 12 months. There's really major bottlenecks right now and being seen in memory care. So we really need primary care docs to increasingly get comfortable with the diagnosis of Alzheimer's disease and using these blood-based biomarker tests. So now, Ren, I'll pass it to you to present a patient case.
Great. Thanks, Suzanne. So this is a patient we're calling Carson, a 71-year-old man. They're a retired engineer. They're coming into their PCP. They have a 15-month history of progressive memory and cognitive difficulties. Not uncommonly, they have vascular risk factors, high blood pressure, cholesterol. These are well controlled on medications, and importantly, they have normal kidney function. They have a positive family history and an older sister who was diagnosed with mild cognitive impairment due to Alzheimer's disease at a similar age 70. And as part of their clinical workup, they had a mini mental state examination with a score of 23 out of 30. So this is scoring in the impaired range. So they're cognitively impaired, but they have no impairment in basic or instrumental activities of daily living and no other remarkable findings as part of their clinical assessment. Their MRI shows mild to moderate parietal atrophy, frontal atrophy, and bilateral hippocampal atrophy. clinical diagnosis, I would say appropriately, is mild cognitive impairment. That's the clinical stage. And the underlying cause of his symptoms is presumed to be Alzheimer's disease. This would be sufficient for a clinical diagnosis of Alzheimer's disease. But now, in the era of biomarkers, their PCP had a shared decision making discussion with them, told them about the clinical diagnosis of mild cognitive impairment, and decided to embark on an understanding of what may be causing of it, and they ordered a plasma p-tau 217 test. This test returned in the positive range, in fact, 3 times the upper cutoff value. So it was positive for the presence of AD neuropathology. So I'll ask you, Suzanne, how would you interpret these blood based biomarker test results in this context?
So, Ren, we know that plasma p-tau 217 is really the best blood-based biomarker to determine whether someone's amyloid positive or negative. And so it's good that that's the test that they performed. Um, and this patient had a clearly positive level, 3 times the cutoff value for being positive. And that really gives us pretty high confidence that they're positive. So, in terms of do they need additional biomarker testing, um, it's, a little unclear. So one question is this a patient that's going to be started on amyloid targeted treatments? If so, he may have practical issues that would potentially make us do additional testing. So, for example, some insurance companies require CSF testing or amyloid PET scans before they will approve treatments. In my state, Medicare will pay for amyloid targeted treatments just based on the blood test. So, if this patient were seen in my clinic and I had um, performed this test, and it sounds like his syndrome is very consistent with Alzheimer disease, and his blood test is clearly positive, we could just start him on treatment. But if he had other insurance issues or potentially we're in another state, he may need another test, really for practical reasons, not really for medical diagnostic reasons.
I would say I agree with your decision making completely. I'm going to move on now and have you answer a challenge question to let us know what you think Carson's primary care physician should do next to optimize his care. So let's talk about what a care pathway would look like to enable the earlier AD diagnosis and treatment. The first step in diagnosis is detection. You have to ask about the symptoms, eliciting a report either by the patient or their caregiver. I think it's a simple question. Do you have any problems with your thinking and memory? In Alzheimer's disease, especially, which is associated with the loss of insight where patients may not be aware of their symptoms, eliciting this information from a caregiver may be preferred. Do you think that they have any problems with their thinking and memory? But if a reliable caregiver isn't present, um, or perhaps there's suspicion on behalf of the clinician, then initiating screening may be appropriate. So, screening patients that are at risk, the major risk factor for Alzheimer's disease is age. So, thinking about screening patients over the age of 65 may be appropriate, or people with a family history that might have a slightly increased risk. And this screening could be done with any number of simple clinical tools, many of which have been used, and increasingly the digital tools that are available, because this will help us confirm the objective evidence of cognitive impairment, which then leads us to a workup to try to understand what the cause may be and may eventually open the door to the AD blood based biomarkers. But just to state what the workup has always been, a neurologic exam, I would say this is a minimum, a neurologic exam looking for things like weakness or the pattern of symptoms that they may have, sending some routine labs looking for liver or thyroid tests, functions, and looking for vitamin levels, performing some sort of imaging, central imaging, usually MRI or other CT scans looking for structural causes of cognitive symptoms like a stroke or tumor or MS that might change the triage pathway downstream. This is important as a first level, and this is routine for the workup of cognitive impairment and is largely unchanged. Once you have this workup done, you have to discuss the results with the patients. If you don't have a clear explanation for the etiology and you think AD is likely, if it's on the differential diagnosis, then having that conversation with the patient about the AD biomarkers that are available, the blood tests, CSF tests, PET modalities, and ordering them if you think clinically indicated is appropriate. Then you'd return the AD biomarker test to the patients. We'll talk a little bit later on about best practices and disclosure. And then after that, one could foresee referral to a memory specialist, especially if the patient is early clinical stage. Their MMSE or MoCA is higher than 20. They have clear evidence of AD neuropathology, no other compelling explanation or contraindication to treatment. This is a patient that I very much would want to see to talk about initiation of amyloid targeted treatments, as well as all the other interventions that we know are effective in this disease. And just to state, a negative biomarker test doesn't mean a referral to memory specialist is inappropriate. If the result is negative or indeterminate, there's still unknown explanation for the cognitive symptoms. It could be a non-AD neurodegenerative disease. And this is something that as a cognitive behavioral neurologist, I specialize in. So that would be an appropriate referral. We're going to go back to our case discussion. We're going to go back to Carson. We've introduced some nuances here to make it a little bit more complicated interpretation. Carson's still 71 years old. He's still presenting to his PCP, but now he has some subjective memory complaints. Perhaps these are milder or tip of the tongue moments or forgetting where his keys are. Uh, Medical history is unchanged with the vascular risk factors, high blood pressure, and cholesterol, though now he does have chronic kidney disease with a GFR of approximately 41. His family history is still positive, but on clinical assessment, his MMSE is now 29 out of 30. So this is in the normal range. So no objective evidence of cognitive impairment and no impairment in his activities of daily living. His MRI findings now are much more subtle, perhaps just mild bilateral hippocampal atrophy. So the clinical diagnosis, the clinical staging is subjective cognitive decline, but the underlying cause of his symptoms is presumed still to be Alzheimer's disease. So there's a shared decision-making discussion with the patient and his care partner about AD biomarker testing options. And his PCP orders a plasma p-tau 217 test, and this is positive at 3 times the upper uh, cutoff value for AD neuropathology. So, Suzanne, what are your thoughts about this case now?
Oh, this is a difficult scenario. This is not a patient I would have ordered a blood test on in the first place because they have subjective memory complaints, normal cognitive function, and it is not recommended to perform these tests in individuals unless they do have objective evidence of cognitive impairment. And then another issue is that he has chronic kidney disease and his EGFR is low enough that it could potentially affect his blood biomarker results. In this patient with a low GFR, would have ordered a different test if I'd wanted to order one. Um, but now we're stuck in this situation where he does have a positive result. It's about 3 times the cutoff value. So it does make me concerned he has Alzheimer's disease pathology. So it puts clinicians in a very difficult situation. And I think there's a couple different ways to go about this. Um, so one is to say we should never done testing in this patient anyway, and let's just do cognitive monitoring on him over time. Um, and then when he declines, then we could potentially do testing. So that's one approach. Another approach is to say, well, he does have some symptoms, and I'm afraid maybe I'm missing something. And he has a pretty significant elevation in his p-tau 217. Maybe I should do an amyloid PET scan. So I, I think there's again a couple ways of approaching this. Neither of these are optimal. I'd have to talk with the patient to figure out kind of the way forward for them. Uh, Ren, what would you do?
Right. Much the same. I think just as you said, when people are in these early clinical stages, but there's still, suspicion for a progressive process, then more active surveillance and monitoring makes a lot of sense to me because I think in the context of the treatment clinic, they're really indicated for mild cognitive impairment and early dementia. That's where we have the evidence base for. There are 2 large preventative trials to see if it works earlier in the disease, but really we don't have evidence. In the earliest stages. But active monitoring to look for that evidence of objective cognitive impairment makes a lot of sense to me, at which time you would embark on that workup. I do have the same pause with the chronic kidney disease. 3 times upper limit of normal, again, is reassuring that that's unlikely to be completely explanatory, but certainly in patients with chronic kidney disease, thinking about alternative modalities like tried and true lumbar puncture or amyloid PET scan can make sense. And in this case, just as you said, it ends up being a shared decision making with the patient about how to proceed. And unfortunately, I think this is not all too uncommon, is a diagnosis in the preclinical or the subjective cognitive decline. And I think we're sort of highlighting perhaps how sticky that discussion can be, and how perhaps the best practice is not to get into it by not ordering the test unless there's objective evidence, because there's a clear care pathway from that point.
Please answer this question on how you would select an appropriate patient for blood biomarker testing.
I'm going to move on to the next variation of this case with Carson. We're going to revert back to our first presentation. Now, Carson has the progressive memory symptoms, but MMSE at 23 out of 30 no longer has the chronic kidney disease to be falsely elevating the results. Diagnosis of MCI presumed to AD, but now multiple biomarkers have been set. They order not just p-tau 217, but also plasma A beta ratios, the A beta 42/40 ratios. And unfortunately, the results return discordant. The p-tau 217 in this case is positive, whereas the plasma A beta ratios are negative. So, Suzanne, probably not an uncommon question. How would you interpret these blood test results?
Um, yeah, so this is not uncommon. This is a pretty frequent issue when multiple blood biomarkers are ordered and they don't all line up. Um, So the first thing to note is the p-tau 217 is the best biomarker of Alzheimer's disease. And so the first test that I would look at would be p-tau 217. And you can see that it's elevated, not by a lot though. So it's high, but it's kind of a borderline high, 0.24, with the top of the reference range at 0.18. So maybe not in a range where I might want to do further testing to confirm pathology. Um, the the other issue is that uh, the amyloid levels were also measured in the plasma. Something important to note is that plasma A beta 42 by itself and plasma A beta 40 by itself are very poor biomarkers of Alzheimer's disease, so they really do not correspond well to amyloid pathology. So you basically just have to not even look at those results because they're not really that meaningful. It's really the ratio that does have predictive value for amyloid status. And this patient is in the normal range, so 0.133, with the reference range being greater than 0.102, being normal. So overall, the picture is that p-tau 217 is elevated, but just by a little bit, and A beta 42 to 40 is normal. So in this patient, I would definitely want to do additional biomarker testing, probably an amyloid PET scan if that wasn't an option, probably CSF testing.
Okay, so now we're going to switch gears and we're going to talk about how to educate your patients about the blood biomarkers before ordering the tests, how to disclose, and how to interpret the results for your patients. When engaging the patients in a pre-test discussion about biomarkers, probably doesn't need to be said, but using plain non-technical language is important. Saying you're sending a test for the proteins that you see in Alzheimer's disease, talking about the accuracy, potential implications in a way that can be understood, I think is very important. This is best done as part of an open dialogue when talking about benefits, risks, and the uncertainties. I really do highlight this is shared decision making. I like to include care partners when present in the discussion. I think that is enriching, especially to provide the support around this. Just to highlight, this is quite an impactful diagnosis for patients. There are educational materials that are available, I mentioned on the next slide, that are patient facing and can be provided, as well as educational opportunities for providers so that they can understand the nuances of the test. But just to say, the benefits of the testing is that they can increase your diagnostic certainty, provide clarity about the etiology of the cognitive symptoms, which are important. The presence of a progressive neurodegenerative disease certainly has implications on long term prognosis over the next decade, including advanced care directives, and then uh, the ability to qualify them for the disease modifying treatments. Again, amyloid confirmation is required. There is a risk in testing, of course. The test performance can vary. There's a lot of tests out there, some as good as the CSF test, some fairly close to chance. And certainly things, comorbidities like chronic kidney disease, neprilysin, certain medications can affect the performance. And with any new tool, we should be aware of the things that affect those tools and communicate those to the patients if they increase our uncertainty. I like to establish realistic expectations up front. A biomarker doesn't, wear a stethoscope and give a diagnosis, but I interpret it in the context of the clinical case. So the result is not final. If there's disagreement, additional testing may be needed. I try to explain that to patients that I have to interpret it, that the result they see may not be the answer. Um, I uh, I like to highlight, I think, this is impactful, this diagnosis. It's one of elderly patients' greatest fears. It's on par with cancer. So when sending the tests that can give a positive diagnosis, I think setting the stage with this pre-test is important to make sure the post-test disclosure conversation goes well, so patients don't feel like they're broadsided by a diagnosis maybe they didn't see coming. And to reduce the risk of misinterpretation because of the nuance I mentioned, I sort of ask my patients, even though in the age of the Cures Act, they get the results as soon as I do, to not look at those results until we have a conversation about what they may mean as part of our scheduled disclosure appointment. Though I will say the success of that is somewhat variable. Um, this is an example of some tools and visual aids that are available, that some of which are patient facing. You can just Google agreed and dementia to find the website for these materials. Um, Disclosing biomarker results, I think, is intuitive to most people in the audience. This is not something that's unusual, but I think it's worth just sort of stepping through how to do it given the gravity of the diagnosis. I like to set the stage by having whatever care partners are present, asking for permission or consent to disclose the results. I have these results that we sent to find out if you have Alzheimer's disease. Is it okay if I share them? Providing a simple description of the results, put the headline up front. The test was positive for the proteins we see in Alzheimer's disease. Describe the certainty of the results. This is a very highly accurate test, which increases my certainty that Alzheimer's disease is present. Connect those results to the clinical diagnosis. I think the Alzheimer's disease explains the memory symptoms that you may have, and then engage in the conversation in discussing the prognosis, different treatment options, both symptomatic and disease modifying, as well as lifestyle modification, as well as next steps. And then importantly, provide options for referral for treatment clinics if that's on the horizon, and additional follow up. I think the initial diagnosis can be quite stunning to patients. And so giving them opportunity and short term follow up, some way of asking follow up questions, I think is often helpful. And then in the case where the biomarker does not give a clear answer, having a discussion about what those next steps and additional testing that may be needed, I think is appropriate.
Before we move on, please take a moment to answer a follow up question about the role of primary care in educating patients about blood based biomarker testing and Alzheimer's disease treatment planning.
Okay, so with that in mind, let's check in with our patient one more time. He has the same vascular risk factors, MRI findings, the clinical diagnosis of mild cognitive impairment with a suspicion for Alzheimer's disease. The PCP has the pretest conversation, orders a plasma p-tau 217 test. This is high performing, hitting the pre-specified sensitivity and specificity to be sufficient as a standalone test to detect amyloid pathology. But lo and behold, the result is negative for AD. So, Suzanne, how would you explain these biomarker test results to Carson?
Yeah, so that's interesting. I would say that some of the most difficult return of results discussions I have are with patients who are convinced they have Alzheimer's and they don't. Um, just because when people have different expectations, it's really challenging when the results don't back that up. Um, and the biggest issue is they sometimes don't feel that their cognitive issues are validated. So they're like, "What do you mean? I'm having all these problems. How can my test be negative?" So it's really important to say, yes, you are having these problems. These are real. It's just not caused by Alzheimer's disease. Now, there are some more caveats here, depending on how high your suspicion is for Alzheimer's disease as the cause of symptoms. there could be false negative results. So, if you are really suspicious that this is Alzheimer's disease, you might want to do a second test. It kind of depends on uh, how much you trust the test that you did. Um, you could also do another type of blood test, just to confirm again that it's negative. I'll say that we often find cases like this where patients are convinced they have Alzheimer's. It looks like it could be Alzheimer's. The test is negative, and if we do additional testing, it's usually negative. That's been my experience. So, so how does this influence the next steps for his care? So we talked some about, yeah, you can do additional biomarker testing depending on how sure you are, or how confident you are in the blood test results. Um, and then, should he be referred on to a specialist? It really kind of, depends. I think that if as a primary care doc, you're not sure what's going on with him, maybe he's distressed by these issues, he thought he had Alzheimer's, that might actually be a very reasonable rationale for referring him on. Um but on the other hand, if, you find, say that you do more evaluation and you find other factors, you find out that he has, severe sleep apnea, for example, um, uh, and then that's, kind of, would be very helpful, and that's actually a really key part of these negative results, is they really should prompt you to kind of, think more deeply about, some of the other common causes of cognitive impairment, which, presumably those have been kind of screened for, but when you get a negative result like this, it's really time to go through and think about in more detail. Am I missing something here? And I would say that that's actually one of the most impactful parts of these biomarkers is we find these negative results, and often we find, yeah, they really don't have Alzheimer's. This is what they do have, and in some cases, those are reversible causes. Do you have any additional thoughts on that, Ren?
I mean, as usual, Suzanne, I agree with you completely. If I have a very high pretest probability and the test agrees with me, sometimes I go looking for a tiebreaker, as you said, to find out to increase that certainty that it's negative. But what I found more and more is the same as you, that it truly is negative, and that what looks for all intents and purposes like Alzheimer's disease or at high suspicion turns out to perhaps have another etiology. We've known this from clinical pathologic studies that the clinical diagnosis is only right about 85% of the time. And so I think we have increased humility around that and identifying even the AD mimics like late, which is TDP accumulation in the hippocampus, sure does look a whole lot like Alzheimer's disease with progressive memory impairment, though a more indolent course and typically in an older patient. But I'm identifying these patients more and more. And importantly, they would not benefit from amyloid targeting therapy because amyloid is not the cause of their symptoms. But they would still potentially benefit from an evaluation by a specialist like myself, perhaps in a complex diagnostics setting, to be able to understand what the cause may be. Whereas a positive biomarker, I think, should route you for expedited evaluation in a treatment clinic for initiation of therapy. So I think this really highlights the triage potential, but then also some of the challenges in those patients that come with a negative test result and how that does require additional sort of thinking. So, Suzanne, now I'm going to hand it back to you to share some tips about how and when to refer patients who have received blood biomarker testing to a memory specialist.
So it is a frequent question, when should I refer a patient or not? Um, and in in general, it's helpful to have this collaborative care team so that you can coordinate care for managing patients. It's also important to implement really defined processes for workup and referral, following a positive, a negative, or intermediate blood biomarker result. And of course, all of this has to be tailored to a patient. So you have to think through, even before you order this test, know, okay, if this is positive, negative, or intermediate, this is what I'm going to do. There are care navigators in some cases that can help patients and families through the process of getting evaluated and potentially treated. We do need additional technical infrastructure to support the integration of this biomarker data into electronic health records. Right now, it's variable. Sometimes there's scanned reports. Sometimes it's structured data in the computer, but it can be quite variable in terms of how this ends up in the chart and how readily different types of doctors can see this. There's also issues about insurance and reimbursement policies. And there's really two aspects of this. One is that blood tests may sometimes be paid for and sometimes not. And it's not always clear if and why those decisions are made. And we're hoping that those decisions become more consistent over time. And another issue is that treatments may not be paid for based on blood biomarker results. So, they are in my state for Medicare patients, but not private insurers. So you have to know what your local insurers will allow you to do based on the results. Um, Again, hopefully over time, these policies will become more consistent and predictable from place to place. So here's an example of a memory specialist referral form following a blood-based biomarker for Alzheimer's disease. And you can download this practice aid, and it basically shows that there's multiple categories of potential testing that have been performed. So this is all information that would be helpful to a memory specialist if these tests were performed as part of their primary care evaluation. Please take a moment to answer the final follow-up polling question. So here are some of the take-home messages from the session today. So, first, expanding blood based biomarker testing in primary care is really critical to optimize the early diagnosis and management of Alzheimer's disease, particularly patient selection for treatment with amyloid targeted treatments. Blood based biomarker testing and patient education and disclosure about test results can be integrated into clinical workflows. And decisions about when to refer patients to specialty care need to be made in collaborations with patients and their care partners and based on the results of these blood based biomarker tests as well as the patient's treatment goals. Ren, I'd like to thank you so much for this excellent discussion about blood based biomarker testing in Alzheimer's. And thanks to all of you for joining us today. You can visit the Alzheimer's Disease Biomarkers Learning Center at pace-alz.com slash AD biomarkers. This provides helpful clinical resources on diagnostic biomarker testing for Alzheimer's disease. Thanks again for joining us. After the session concludes, please visit pureview.com slash plasma to claim credit and access the activity materials, and stay tuned for the online activity based on this event.